Welcome to AETCM, the Emergency Medicine Channel. Today, I'll be presenting a case of a 30-year-old male patient who presented to ER with complaints of persisting diplopia since 2 days. On initial 10-second assessment, patient is conscious, oriented, speaking in full sentences. Airway was patent, there was no gurgling sounds. Breathing saturation was 99% on room air, respiratory rate of 18 per minute. Air entry was bilaterally equal, no added sounds. Circulation, heart rate was 74 per minute, BP of 126, 80 millimeters of mercury. Disability GCS was E4, V5, M6, pupils equal and reacting to light, 2.5 millimeter, moving all four limbs. GRBS was 360 milligrams per deciliter. Exposure wise, temperature was 97.6 degree Fahrenheit. Adjuncts of primary survey, we have taken one ECG which showed a normal sinus rhythm. VBG taken showed a pH of 7.42, bicarb of 23.6, and sodium of 138 and potassium of 4.2, creatinine of 1.4.
Sugars are normal?
Sugars 360 milligrams per deciliter. No evidence of any high iron metabolic acidosis in VBG. Okay. Secondary survey, patient was apparently asymptomatic till 2 days back when he had acute onset of double vision while he was driving back home. And he went home and slept, but after waking up, he had persisting binocular horizontally separated double vision. And it was more on looking towards the right side. And it was there was little double vision on looking towards straight, but more it was on looking towards right side. And there were no any associated diurnal variations. It was persisting throughout the past 2 days. And there was no aggravating or relieving factors. There was no drooping or retraction of eyelids, headache, vomiting, no facial numbness, jaw claudication, no loss of vision, no complaints of unilateral weakness, swaying while walking, any neck stiffness, fever, no history of dysphagia, dysarthria. Allergic history, there is no known drug allergies. Patient is a known case of type 2 DM and hypertension. Type 2 DM since 22 years and hypertension since 10 years. For diabetic, he was taking metformin, 500 mg BD with glimepiride 1 mg BD and also taking sitagliptin. After that, patient had actually past history. Patient had actually a similar episode which happened 15 years back. That is double vision, which was that time he was saying it was more on looking towards left. And he had with associated facial deviation, which was treated with steroids. And on examination wise, patient is conscious, oriented, febrile, moderately built and nourished. There is no pararictus, cyanosis, clubbing, lymphadenopathy or pitting pedal edema. Systemic examination wise, CNS, GCS was E4, V5, M6, pupils equal and reacting to light, 2.5 millimeter equal.
What is the importance of pupil in this case?
In this case, if there is any pupil...
So if you take diplopia, 3 important causes you can see. Diplopia as such. Yes. What are the 3 important causes? Diplopia is ophthalmoplegia. It can be either due to third nerve palsy,
fourth nerve palsy, sixth nerve palsy.
These are the major causes. Yes. Okay, there may be other causes, but as a normal routine doctor, we should know all these three important reasons. If you have a third nerve palsy and diplopia, what is the clinical finding?
With the dilated pupil will get because the parasympathetic
normally patient will never complain about diplopia. Why it is like that? Third nerve palsy, if you have seen third nerve palsy, you will understand that. What is third nerve palsy? You have complete ptosis.
Yes.
So that side patient is not seeing anything. Their main complaint will be ptosis. Okay. But whereas in other two countries, third nerve palsy, because of ptosis, they are not observing. But when we are examining the patient, you can get diplopia. Whereas in sixth nerve palsy and fourth nerve palsy,
they'll complain of horizontal diplopia or vertical
sixth nerve palsy, where will you get diplopia?
More on the side of action of lateral rectus.
Suppose the right side is involved. When the patient looking towards the right side, you can get diplopia.
Horizontal diplopia usually.
Other one?
Fourth nerve palsy usually will present with vertical diplopia with maybe an oblique component also. So the patient will have
superior oblique. Superior oblique is just opposite side.
So they might tilt the head little for adjusting for the vision.
Okay. So main problem will be this sixth nerve palsy. Most of the time, sixth nerve palsy patients have more symptoms than other things. But you know that third nerve palsy patient can have severe diplopia, but unfortunately that is masked completely by ptosis. Okay, if you take only ptosis, there are two types of ptosis. What are the two types of ptosis? One is partial ptosis, other one is complete ptosis. In third nerve palsy, you get partial ptosis or complete ptosis.
Complete ptosis.
It is complete ptosis. Where will you get partial ptosis? Huh? Partial ptosis. Okay, myasthenia is correct. What you are telling, bilateral ptosis. We are talking about unilateral. Unilateral partial ptosis is a feature of Horner syndrome. Classically, it is Horner syndrome. What is the muscle paralyzed there? What is the muscle? It is Muller's muscle. Whereas in third nerve palsy,
levator palpebral superior.
Okay, so the both muscles are different. Okay, 30% is contributed by Muller's muscle. That is the problem of ptosis in that. In Horner syndrome, what is the size of the pupil?
Horner syndrome.
Third nerve palsy, it is dilated.
Dilated, here it is meiosis.
Here it is meiosis. So that is the main difference between ophthalmoplegia in Horner syndrome and this one. Okay. Now you take other two conditions like what are the other features of third nerve palsy? Which are the muscles involved there?
So there will be lateral palpebral superioris, then there is superior rectus, inferior rectus, medial rectus, and inferior oblique.
Okay, so these are the things. Okay, now there are something called as surgical third nerve palsy and medical third nerve palsy. What is that? Surgical third nerve palsy, medical third nerve palsy. What is that?
Actually, we can divide it into based on which side is which part is affected. Either it can be the nerve, muscle, or the neuromuscular junction. So if there is a nerve involvement, we can divide it based on compression, secondary to a tumor, trauma, or due to any aneurysm.
They all called as surgical third nerve palsy. Medical third nerve palsy is seen in.
Then there can be demyelination, infections causing the
especially in diabetic, like your patient
microvascular ischemia.
Diabetes is the most important cause for medical third nerve palsy. Like you told, demyelination also can have third nerve palsy. In that, diabetes is the most common, both for all this, like what you told is lateral rectus palsy, even third nerve palsy, it is most common. Okay, how do you differentiate this surgical and medical third nerve palsy? How do you differentiate? There is a most common associated cause,
trauma, associated symptoms or associated history will be present.
Both will have third nerve palsy. How do you differentiate then?
If there is any trauma history that we can elicit, or
trauma
we can
history is there.
Otherwise, if any tumor is there,
diabetic patient come with trauma. How do you differentiate that? Diabetic patient come with a trauma.
Fundus we can check for
external involvement is not diabetic central involvement.
What is the main difference in this? These all things are basics we should know. What is the main difference between third nerve palsy because of surgical causes, third nerve palsy because of medical causes? Why we need this? Because in surgical cases we need to take an MRI and rule out the reasons for that, aneurysm, trauma, anything. Okay. But whereas diabetic induced third nerve palsy, nothing is required. You have to give aspirin and other supportive medicines. So how do you differentiate? Bilateral is seen in bilateral, where you get bilateral third nerve palsy.
There will be other nerve involvements also.
Bilateral third nerve palsy, where will you get? You have to tell me fast. It is in snake bite. This is a feature of snake bite. But here, pupil is the most important thing. Pupil will be spared in
diabetic vasculopathy.
Okay, whereas in pupil is classically involved
in surgical trauma, tumor.
Trauma tumor, outside nerves, peripheral nerves.
Okay, so that will be the classical finding. So that clinically you should know that. Otherwise, what will happen? We unnecessarily will be ending in doing MRI for all these patients. But here it is an entirely different issue. Your sixth nerve palsy had occurred. How do you manage this case?
So initially, since as we said about the causes, we have to actually first of all see if it's if there is any red flags associated with the diplopia, or is it just a simple diplopia.
So any diplopia red flags you have to see, because you have already told aneurysms, trauma, tumors, bleeding to tumors are very important.
So first from history itself, we'll have to ask for the patient if he's having a horizontal separation of the images, or if there is any vertical separation of images. We can ask the patient if you're seeing the second image as horizontal, or is it above.
Okay. Ideally, in neurological examination, what they do, I don't know whether they do or not, they'll have a specs with two colors.
Yeah, that is a worth 4 dot test.
So that is the ideal thing to be done, but in emergency it may not be practical.
So and then we can ask about the onset, the duration, and the frequency of occurrence.
Okay.
Or if there is any variability with time, like if it is more in the morning, it can be more of a thyroid ophthalmopathy, orbitopathy due to the inferior rectus stiffness.
Okay.
Or if it's more towards the night, it can be due to a fatigability issue due to a myasthenia gravis component.
Okay.
Then we can ask for the distance. If it usually lateral rectus palsy patients, they will complain of diplopia when they look at a distant object.
Okay.
Whereas if it is a nearby object, it can be fourth nerve involvement also.
Okay.
And other thing we can ask is any aggravating or relieving factors. If the patient says a
Can
diplopia,
headache associated with all this third nerve palsy, sixth nerve palsy, fourth nerve palsy?
yes, that we have to. If there's a headache, that's also a red flag, and we'll have to based
That
on
is
the
a red
severity.
flag. Actually that's a red flag. But a patient tells that every time I get headache and diplopia for a long time, every time I get headache, I am
Ophthalmoplegic migraine in children.
thermoplegic. So
Usually seen in children.
migraine can have all the features of diplopia,
Diplopia.
ptosis, everything. Okay.
And then we'll have to ask for any associated symptoms, as in if the patient is keeping any position to adjust for that diplopia, as in fourth nerve palsy, they'll have a mild head tilt.
Okay.
Then we'll have to ask for any associated ptosis, the eyelid, if there is any ptosis we are seeing, or any retraction or proptosis symptoms.
Okay.
Then also red flags, you have to ask for any severe acute onset headache associated with the diplopia.
Okay.
You rule out any aneurysm, rupture or any aneurysm. And also if there is a gradual onset of headache worsening, then we can suspect tumor also. And other thing is the facial numbness or any other cranial nerve involvement has to be asked. And if there is multiple nerve involvement, it can be at the level of the cavernous sinus level. So any cavernous sinus related tumors.
That third nerve will be commonly involved.
Yes, third nerve will be most common. ICA aneurysm and all we have to see.
Okay.
Then we'll have to see for like facial numbness, other cranial examinations, cranial nerve histories you have to ask. Then we'll have to see for
Which cranial nerve will produce facial numbness?
facial numbness, usually trigeminal, the
Fifth cranial.
fifth cranial. And also we'll have to see for any history of jaw claudication or any headache or more of the temporal region headache in more than 50-60 years age, we can suspect a giant
Cranial
cell.
nerve fifth root will extend up to what level in the spinal cord? It extends up to that level. That is a problem. So not only that problems in the midbrain, no? Midbrain, it can even the lesions down also can produce numbness.
And then that also is true. Jaw claudication, temporal headache, to rule out any giant cell arthritis. These people
Giant cell arthritis is common in which type of patients?
more than 50-60 year age.
Aged patients.
50.
Okay.
And then they also can present amaurosis fugax also, complete transient loss of vision also. Then we'll have to see for any progressive worsening of symptoms towards night that imply myasthenia gravis.
Myasthenia, okay.
And then proptosis symptoms like that. Then coming to examination wise, we'll have to do first of all local examination. We'll have to see the eyelid initially. So the eyelid, if there is any ptosis or there is any retraction of eyelids, have to be seen. And then we'll have to look for the pupils. Pupils, if there is any asymmetry, anisocoria or any unilateral dilatation of the pupils have to be seen to look for the third nerve palsy.
Okay.
And then we'll have to look for any the motility of the that is the major mobility or motility and alignment of the eyes you have to see. So that we can check in all directions of gaze. So we can do either a H test.
Okay.
We can do, and then we can do check for the obliques also.
Okay.
And then
what will be the finding in multi-system atrophy? You know what is multi-system
atrophy? Sixth
What will
nerve
be the-
palsy.
What will be the finding? There are also ophthalmoplegia is there. That's a type of Parkinson's.
Parkinson's variant.
They will not be able to look down. Frequent fall when they are climbing down the steps. That is a classical finding of multi-system atrophy. Their the downward gaze is paralyzed. Downward both eyes. Okay. Whereas in all these cases you get only unilateral. That's why you are getting diplopia. There you may not get diplopia.
And then we can also check for saccadic movements also, any issues there with that. And if there is any red flags, then we'll have to go further with imaging.
Okay.
We can take an MRI or CT.
Okay.
And if there is any third nerve involvement also, we can add on with the angiography also, CT angiography or MR angiography. And if there is isolated fourth and sixth nerve involvement, if you are in a peripheral setup, we can actually observe the patient for any worsening of symptoms or any improvement.
So here MRI is taken.
Yes, sir. Here actually,
Any findings?
There is only chronic lacunar infarcts present. So course of the sixth nerve was normal, and also we had the vision assessment. Also, it was normal side, 6/6 it was there, and we also had from neurology side they had done a Worth 4-dot test.
Okay.
That is with the red glass in right and left side green glass.
Okay.
And in that actually there is 4 dots. So down there will be a red dot followed by 2 green dots and 1 white dot. So in this patient actually he had seen 3 green dots and 2 red dots.
Okay.
So, and also Diplopia charting was done, which showed maximum separation at dextro depression position.
Okay.
And dilated fundus examination was normal bilateral eye. And after that MRI we had planned for LP from neurology side. They had wanted to rule out infection, any infection causing the issue, and then plan on starting pulse, steroid pulse. So LP total cells were 5 cells only, and protein 66, glucose 105 with GRBs 170. So they had also sent vasculitic workup also. So ruled out any cause for vasculitis causing the issue. And since after ruling out any infection, they had started with the methylprednisolone pulse dosing for 5 days, and then progressively patient had improved. The diplopia had improved progressively.
Okay. So what do you think the reason for isolated cranial nerve palsy is?
Most common reason is the diabetic vasculopathy.
Most common case of vasculopathy in a diabetic patient is
diabetic
diabetes.
vasculopathy.
What is the treatment for that?
Treatment sugar group GRBs controlled.
Should be controlled.
Controlled.
Should give aspirin.
Aspirin.
Aspirin is a treatment of choice. But there are conditions like vasculopathies are there other than diabetes. There are different vasculopathies, like you can get small vessel vasculitis. If in that case, you give steroids or steroid sparing agents. If it is multiple sclerosis, again same findings can be there, but there should be some lesion in the MRI scan. Okay, that is not there. It is mainly because of the vasa nervorum involvement. There is a blood vessel to your nerve that is hypertrophied and blocked. That is the reason for all these things. Okay, that is classically seen in diabetes, especially third nerve palsy. Okay, you can get other cranial nerves also, but classically you get in third nerve palsy, and that pupil will be spared.
Right.